Hi, everybody. Today is going to be the last time that you're hearing from me for this course. From now on, we're just going to be hearing from you guys in your presentations. So congratulations for making it this far. So today, the last lecture is going to focus on personality disorders. And this is kind of, as psychologists, one of the more challenging areas that we have to work with because we don't have our diagnostic criteria for these disorders are not ideal. In addition, we don't really know much about how to treat these types of disorders. And so what we'll talk about a little bit today is what we do know. I think that there still needs to be a lot of research kind of done into personality disorders. So what is personality? Contrary to kind of like the other disorders we've talked about, which kind of have discrete periods of onset or offset usually, a personality is a unique and long-term pattern of inner experience and outward behavior. And it's really not 100% clear that we can change our personalities, that this is something that we just kind of have. It tends to be consistent and is often labeled in terms of a trait. So if we think about the state trait way of thinking about symptom presentation, so the state would be, I'm feeling upset, because that's you're feeling upset in the moment. A trait would be, that you're kind of a glass half empty kind of person, a pessimist, I suppose. But they can also be flexible because it allows us to learn and adapt to new environments. But those who have personality disorders struggle with that because the disorders kind of inhibit them from being able to then get involved and adapt to these different types of environments. And so what a personality disorder is, as opposed to kind of personality, is an enduring rigid pattern of inner experience and outward behavior that impairs their sense of self, emotional experience, goals, and capacity for empathy and or intimacy. And so oftentimes, like we talked about the distress and impairment criteria, oftentimes people with personality disorders aren't particularly distressed by their symptoms. It's really that they're causing distress for others, or they're just kind of not functioning as well in their environment, because for them, this is who they are. And so they don't necessarily know another way of being. And so, as I mentioned, it kind of leads to pain for other people as opposed to themselves. So having a family member with a personality disorder will not necessarily distress them, but could distress you immensely. You typically notice personality disorders in adolescence or early adulthood, because that's when we kind of develop. I think as children and young adolescents, we're trying on different personalities. Or if we have kind of different quirks, they're not quite as noticeable yet because, these things are still being learned. But as we get older, these things become more ingrained. Then we see them more clearly. It's very interesting because they say you turn into your parents. And, I watched my grandmother, who was a rather difficult personality. We questioned whether she had a personality disorder, but my dad would always complain about her and her behaviors. And now that he's getting older, I see more and more that he's starting to take on a lot of her traits. And I'm even seeing in my brother that he's starting to behave like my father. So I don't know if these are, there's a lot of, we'll talk about kind of how they're transmitted, but there's a lot of thought that there's some hereditary aspects of these, or we just learn how to behave from watching those around us. As I mentioned, these are the most difficult psychological disorders to treat. Many people don't even know that they have a personality disorder. It's only because their environment may be impacted by the way they're behaving that it would even come to the attention of somebody in the mental health profession. But it's estimated that anywhere between 9 and 13% of all adults may have a personality disorder. So they're quite prevalent. When we had the old Axis system in DSM-4, personality disorders were found on Axis 2. So initially in the revamping of the DSM, there was going to be a continuum of, personality, because again, this is not like all or nothing. A lot of us have a lot of these traits, and you may recognize yourself in some of the disorders or the personality disorders that we talk about. but you may not meet full diagnostic criteria. And there's a high degree of comorbidity or overlap between symptoms, which is why people have long complained that, there's not a lot of specificity with these disorders, which is one of the things that we require when giving something a name. However, they've kind of more or less kept it as it is. There's been very few changes. So the DSM-5 identifies 10 personality disorders and separates them into 3 groups or clusters, which has kind of been the case for a while now. So we have the cluster A, B, and C. So A is the odd or eccentric behavior cluster, B is the dramatic, erratic, and emotional behavior cluster, and C is the anxious or fearful cluster. So similar, as I mentioned, there was a talk of, kind of putting these on a continuum, but DSM-5 still continues to use the categorical approach. So you either have or do not have a personality disorder. But generally, as we mentioned, people who have personality disorders are not particularly impaired or experience distress themselves. But we see some of these things that are different actually in clinical practice, because you'll see people, as I said, kind of exhibiting a lot of these symptoms at a sub-threshold level, which would make sense for it to be kind of a continual diagnosis. And I think that in subsequent versions, hopefully we will see more of this kind of continuum of personality disorder. So as I mentioned, there's so much overlap that it's really hard to distinguish one from another. And oftentimes people will be diagnosed with more than one personality disorder, which when you really think about it, doesn't necessarily make sense. So again, this points to the fact that these diagnostic criteria are not necessarily where they need to be yet. So there's been concern raised about the validity and reliability of these categories. So here are the general criteria for personality disorder, and then we'll go into each individual disorder itself. So it's an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. So their personality doesn't mesh with society, which is why kind of we recognize there's something wrong. One of my professors once told me that the way to kind of know somebody has a personality disorder is that they kind of irritate you or bother you, or they elicit strong emotions in you as the clinician, and that's often indicative of a personality disorder, because that's the behavior they're eliciting in you is often something that will be elicited among other people as well. So, so the pattern is manifested by in 2 or more areas. So cognition, so the way they perceive and interpret themselves, other people, or events, their affectivity, their kind of emotional responding, for example, their interpersonal functioning, and their ability to control impulses. And you'll see that with different disorders more than others. And so this pattern is inflexible, and that's where the kind of the enduring personality part of it comes. Like, so they, all of us have moments where we are more rigid in our thinking, but this can change over time. Somebody with a personality disorder, this is the way that it always is for them. And it causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. So oftentimes, as I mentioned, it's not going to be the person themselves who comes to see the psychologist, but because they're told to come by somebody else, or they're bothering other people, or they're having problems in work or other areas of functioning. And this is a stable, long-during problem, and it's definitely usually see the onset in adolescence or early adulthood. So cluster A is the odd or eccentric kind of personality disorders, and these have a lot of overlap with the schizophrenia spectrum disorders, and there's also a lot of talk that these are actually, there's a lot of overlap between the diagnoses of the psychotic disorders and these personality disorders. And so this again kind of points to areas of validity and reliability. But paranoid personality disorder is a pervasive distrust and suspiciousness of others such that their motives are interpreted as malevolent. You see this in early adulthood, and it presents in a variety of contexts with 4 or more of the following. So these are kind of the paranoid type of people, like when you say, quote unquote, she is paranoid, this is what they're referring to, this paranoid personality disorder. So it's not paranoid to the extent that it's like psychotic thinking, but they're just very suspicious of everybody's motivations. These are the people that are feeling constantly worried that they're being hacked or the government is spying on them or things like that, but there's actually a basis to these. These are not psychotic in nature. So they suspect that others are harming, deceiving, or exploiting them. Now, here the key is sufficient basis. So these are not kind of out of the blue, but these are kind of within the realm of possibility. They're just more suspicious of others, that the government is spying on us. And based on what we know, that's probably accurate to a certain degree, but they just seem more concerned about this than the average person. They're preoccupied with unjust doubts about loyalty or trustworthiness of friends or associates. They're worried that their friends might betray them. They're reluctant to confide in others. There's an unwarranted fear that information may be maliciously used against them. They read hidden or demeaning or threatening meanings into benign remarks or events, and they bear grudges. They're unforgiving of insults, injuries, or slights. They perceive attacks on their character or reputation that, where no apparent attacks really exist, and they're generally suspicious without specific justification, specifically regarding fidelity of those with whom they're in a romantic relationship. So you can see that this is hard to distinguish sometimes from paranoia, we've seen in psychotic disorders. But what you kind of have to look here is that this is an enduring pattern of behavior. It comes on in adolescence, and it tends to be pervasive across multiple contexts. And it's just this general kind of fear or paranoia. So they cannot have schizophrenia, bipolar, depression, or other depression with psychotic symptoms, or any other psychotic disorder. So we see this in about 2 to 4% of the general population, about 10 to 30% of inpatients, and about 2 to 10% of outpatients. It's greater among male than female, which kind of suggests that there might be, something genetic going on here. So because of this behavior, they drive other people away, which then leads them to increase the thoughts that they can't trust other people. In terms of cognitive therapy, you'd want to target things such as their beliefs and feelings of inadequacy, because they start to feel that other people don't like them, and also to work on reducing their paranoia and test out some of their paranoid hypotheses. But again, as we really don't have any evidence-based treatments for these types of personality disorders yet. So, this can help and improve person's functioning, but that we have really the data that shows that this kind of works is really not necessarily true. You want to rule out cultural factors because, for example, immigrants or political refugees may have reasons to fear government interventions, and so you have to figure out where this kind of thing is warranted and where it's not warranted. For example, Assange, the guy from the WikiLeaks might be paranoid, and he has a right to be paranoid because people probably are spying on him. They may be perceived by others as being fanatics. They may join cults, like doomsday cults, things like that, where they believe that, that people are spying on them, things like that. And they generally don't have a good sense of humor. It may be a precursor to psychotic episodes, and these individuals might have transitory psychotic symptoms, which then, kind of blurs the line between what is a psychotic disorder and what is this personality disorder. It's proposed that it's caused by parental neglect or domination, abuse, isolation, poor peer relationships, exposure to violent adults, infliction of pain. And those with paranoid personality disorder tend to have relatives with schizophrenia, again, leading to think that this is some derivative of schizophrenia. Schizoid personality disorder is also part of this cluster A. I always thought it was schizoid, but apparently you pronounce it schizoid, which kind of sounds weird. And I remember the first time I heard that, I thought the professor was inaccurate, but apparently it's true. So this is more closely related to what you would see amongst those with the negative symptoms of schizophrenia. So it's a pervasive pattern of detachment from social relationship and a restricted range of emotional expression in interpersonal settings, with 4 or more of the following. They don't want or desire close relationships or even being part of the family. They always choose solitary activities. They don't have many sexual experiences with other people. They have very little pleasure in activities. They lack really any close friends other than first-degree relations. They really are indifferent to praise or criticism from others. They display emotional coldness, detachment, flat affect. So you can see that there's a lot of overlap between this and symptoms of a depression. You can also see this might be similar to somebody on the autism spectrum disorder. Or it can be kind of the negative symptoms of schizophrenia as well. So it's very hard to diagnose this. It's estimated that, again, the prevalence rate is somewhere between 3 to 5% of the general population. These people tend to be more reclusive. They don't seek out treatment because they're kind of happy the way they are. It doesn't, and they don't particularly bother anybody else. We tend to see it again more in males than females. It's questioned as to whether this is kind of, if you think of schizophrenia as a spectrum, that this is kind of on a milder end since they can function. They might be, people who are working with computers at home. They don't have to go into the office, for example. Um, we might see that this might be kind of prodromal for a delusional disorder or schizophrenia, again, questioning whether this is actually a personality disorder. And you want to rule out sociocultural factors. So, people in more rural environments, which tend to have more solitary existences, maybe, will want to be more isolated, or immigrants, for example, who don't speak the language, or are kind of don't want to, are scared to kind of integrate with other people who are from different cultures. And so you have to rule out some of these sociocultural factors. Schizotypal personality disorder are a pervasive pattern of social and interpersonal deficits marked by acute discomfort or reduced capacity for close relationships, as well as cognitive perceptual distortions and eccentricities of behavior. So these are like the kind of the eccentrics that we see in our society, the ones that like the kind of like the Kramer on Seinfeld characters, except that he does want interpersonal relationships, but you have some ideas of reference, but not necessarily delusions. So there might be some strange ideas about kind of the way things happen. Odd beliefs or magical thinking that influences behavior, like ESP, telepathy, sixth sense, superstition, bizarre fantasies, or preoccupation. They might have some strange bodily perceptions. There may be odd thinking or speech. Again, if you think about kind of the Kramer character, there might be some suspiciousness or paranoid ideation, inappropriate or constricted affect. The behavior is odd, eccentric, or peculiar. They may lack close friends other than relatives, and they may have social anxiety that doesn't lessen with familiarity. So as they get to know people, they still feel socially anxious, but it's not like, and this is where the differential diagnosis comes into play. It's not because they're afraid of the negative evaluation from others. It's rather that there's some kind of paranoia. So as you see here, there's probably a great degree of overlap with things such as schizophrenia, and the differential diagnosis might be particularly challenging. It's estimated that here we see this in between 1 to 4% of the population, with a small percentage of those with this diagnosis eventually developing schizophrenia, again, more prevalent in males than females. These individuals have a hard time expressing emotions, and again, similar to some of the other personality disorders along this cluster A, they're not necessarily affected by praise or criticism. Again, it's thought that if we conceptualize schizophrenia on a spectrum, this might be there, that, this is kind of the next step up from schizoid personality disorder. You're seeing a lot more of the positive symptoms. So whereas schizoid would be the negative presentation of schizophrenia, this would be the positive, but they're still functioning more or less in their environment. You want to take into account things like cultural factors such as, speaking in tongues, people who believe in voodoo, sixth senses, people who believe in telepathy. I mean, there are people who do believe that as part of our mainstream culture. We see this often, which is comorbid with depression and anxiety. Brain scans have shown prefrontal deficits, which can suggest some kind of, biological or brain impact. And we're seeing kind of sustained attention deficits. And again, thinking back to Kramer, like he seems to not be able to focus on anything for more than a second. Cluster B is the erratic, dramatic, and emotional disorders. So these, these are kind of quite contrasted with those in cluster A. So cluster A tend to withdraw. Cluster B are the ones that are causing and wreaking havoc and destruction in their environment. So we see the borderline, the antisocial personality disorder, and the histrionic personality disorder. So most of you are probably familiar with borderline personality disorder. This is one of the more difficult patient populations to work with. So here the diagnostic criteria involve a pervasive pattern of instability in interpersonal relationships, self-image, and affect, marked by 5 or more of the following: frantic or real efforts to avoid or real or imagined abandonment, um, and pattern of unstable or intense interpersonal relationships that alternate between extremes of idealization and devaluation. So what we see here as therapists is one day we're going to be the best therapist in the world. Other days we're going to be the worst therapist in the world. They're going to love us. They're going to hate us. And you see this a lot in their relationships. They're frequently fighting with their friends. They're breaking up with their lovers. They have an identity disturbance, so there's an unstable sense of self, such that they don't know who they are, what their career goals are, things like that. And then we're seeing impulsivity in at least 2 different areas that are damaging, such as spending, sexual. They'll have many sexual partners, for example, reckless driving, binge eating. And so this is where the differential diagnosis comes into play. It's important to distinguish between these things and then, binge eating disorder, for example, or bipolar disorder. We see recurrent suicidal behavior, gestures of threat, or self-mutilatory behavior. About 60 to 80% of those with BPD engage in some sort of self-mutilation. They do this to regulate emotions. Or you'll see recurrent suicidal behavior that is not necessarily with the intent to die. There's affective instability due to marked reactivity of mood. So you'll see them moving from very happy to very sad to very angry within short periods of time. There are chronic feelings of emptiness, very lonely, depressed, which is often comorbid with borderline personality disorder. Inappropriate or intense anger or difficulty controlling anger. So when people get into fights, you'll see them throwing things, becoming physically aggressive. And they may become paranoid or start to dissociate when stress gets higher. The prevalence is anywhere from between 1.5% to 6%. You see it about 2% of the communities and about 10 to 15% of the outpatient population. About 75% of those with BPD are female. There is a high suicide risk, so even though they have multiple suicide attempts, these can often become fatal. And so, one of the key targets of DBT, which is dialectical behavior therapy, is the suicidal behavior. We see high rates of comorbidity with depression and substance use so they medicate themselves in order, because the emotional ability can be a lot to handle. Very much viewing the world in terms of dichotomies, like I love you, I hate you, good, bad. There's the self-destructive behaviors. You'll see high levels on the NEOPI, high levels of neuroticism. This is tending to kind of burn out. So they say, I've heard people say this is like the antisocial personality disorder of the female gender. And so, the peaks primarily kind of age 20, 30, and then over time we tend to see these symptoms kind of wane. I think people kind of get tired out of the drama. It's a controversial diagnostic category due to poor reliability, but also the stigma associated with the diagnosis. Like a lot of therapists, I know if somebody says they have, BPD, that therapists will not see them because these are often high-need clients. It's thought that BPD results from childhood abuse and neglect, so we see high prevalence of those with childhood sexual abuse. They also report having been physically and verbally abused as well, and there's a lot of invalidation of their feelings. Like, if a child is crying, say, stop crying, you don't feel sad, and so they don't really understand how to understand their emotions. So there also might be that they're born with a different type of temperament where they're more susceptible to emotional cues. They experience their emotions more intensely, or they may be more aggressive. We do see kind of a high degree of comorbidity among monozygotic twins, with a lower degree among dizygotic twins. It's not clear whether this is due to environmental or genetics, because we don't have any adoption studies yet. So it's it's possible that there might be kind of these temperamental traits that are inherited, and then due to the environmental circumstances, those can then lead to the expression of these symptoms. We do see neurotransmitter differences among those with BPD. Again, it's unclear what came first, the chicken or the egg, or are these a result of the abuse, which then cause changes in the biochemistry, which then can lead to BPD. We do see things such as reduced cognitive control and increased impulsivity, which can be linked to the prefrontal lobe stuff. Another one of the histrionic personality disorder of the cluster B disorders is histrionic personality disorder, where we see a pervasive pattern of excessive emotionality and attention seeking. So these are the people that are kind of over sexualized in a sense, that kind of seek attention from people in negative ways. It's often confused with borderline personality disorder, but they want to be the center of attention. They feel uncomfortable in situations where they're not. They often will interact with others in inappropriately sexually seductive or provocative ways. You often see rapidly shifting emotion and shallow expression. Kind of think about Marilyn Monroe here. If any of you have kind of followed her, this might be something that would be similar to a presentation that she would display. You consistently use physical appearance to draw attention to themselves, has a style of speech that is excessively impressionistic and lacks detail. They can be very theatrical or very dramatic. They're very suggestible, and they may consider their relationships to be more intimate than they actually are. Again, here we see more females than males. Generally in the population, it's about 2% prevalence. It's unclear how much of this causes significant impairment, and is this somebody just adjusting to their environment? For example, you may see more of these types of people in Hollywood, because this is where that type of behavior would actually be reinforced. People like that kind of behavior. So is it really a violation of cultural norms? Is it playing into sexual stereotypes? We know very little about this disorder. Is it, what is the genetic transmission? Is this due to environmental factors? And so, much more research is needed into this diagnostic category. The last personality disorder in this category is narcissistic personality disorder. There's somebody in the White House right now who would meet criteria probably for this disorder. Not to say that we diagnose people that we do not see in practice. So you did not hear that from me. But it's a grandiose sense of self-importance. They exaggerate achievements, talents, and want to be recognized as superior without any evidence for that. Preoccupation with fantasies of unlimited success, power, brilliance, beauty, and ideal love. They believe they're special, unique, and can only be understood by other high-status folks. They require excessive admiration. There's a sense of entitlement. They take advantage of other people. They exploit others. They lack empathy. They're unwilling to recognize or identify the feelings of other people or their needs. They are envious or believe that other people envy them, and they're arrogant, haughty in terms of their behavior. Again, not naming any names. We may know some people who have these types of characteristics these days that are kind of in the political arena. Primarily males, as opposed to the other erratic, dramatic, emotional PDs. You see it anywhere between 1% and 6% in the general population. You often see it surprisingly comorbid with depression, and the theory behind this is that these are people with really actually low self-esteem, and they've somehow kind of developed the reaction formation, like the Freudian term, because they're afraid, because they do fear deep down that there's a sense of inadequacy or worthlessness, and so they then kind of become the opposite. It's possible that it's heritable, although this might be a trait that's transmitted from generation to generation. And then we have antisocial personality disorder. So where you have 3 or more of the following: failure to conform to lawful behavior, deceitfulness, impulsivity, irritability or aggressiveness, reckless disregard for safety of others, consistent irresponsibility, or lack of remorse. So you have to have these symptoms from age 15 onwards. Under 15 would be diagnosed with a conduct disorder. You see this diagnosis very frequently among those in the criminal justice system. So there's a failure to obey laws and norms. So you'll see them frequently arrested. Just because people are arrested doesn't mean they have ASPD, but you'll see because of their behavior, they do get arrested frequently. So you have to make sure that you are not using the arrest solely for the diagnosis. There's lying, deception, and manipulation for self-profit or amusement, and this has to be an enduring pattern of behavior. So this is not just once or twice to not get yourself into trouble. This has to be throughout the course, of multiple years that you're seeing. Impulsive behavior, irritability, and aggression is manifested by frequent assaults of others or fighting, and again here the key is frequent. Blatant disregard for the safety of self or others, pattern of irresponsibility, and a lack of remorse for emotions. A lot of people get ASPD confused with psychopathy. The two, while many people with psychopathy may also have ASPD and vice versa, the two are distinct constructs, and psychopathy is not a diagnostic category. So we see this a lot with those who have substance use disorders. The two are highly comorbid, but we also see this as highly prevalent in the criminal justice system. You have to be 15 years of age to get this diagnosis, and prior to that you would receive conduct disorder. But you want to see that this pattern of behavior has started in adolescence, and so usually the conduct disorder has to precede the ASPD. It's 4 times more common in men than women. It's thought that there might be some gender bias here, and that, as I mentioned earlier, the women get borderline personality disorder and the men get ASPD. The estimates are anywhere from 0.02% of the population to 3% of the population, and we see there are estimates of up to 40% in the criminal justice population. And because these people are often in contact with the law, a lot of the research on those with ASPD has taken place in the criminal justice system. This is a diagnostic category that you will see frequently in your work if you do work in the criminal justice system. And we do see higher rates of substance abuse, as I mentioned earlier. It may be learned through modeling or unintentional reinforcement. There also might be cognitive biases where they view the world as a very hostile place and they don't necessarily pay attention to other people's needs. We do see lower levels of serotonin, which can impact impulsivity and aggression. Deficits in the frontal lobe functioning, again related to impulsivity and aggression. But we do see lower levels of anxiety and arousal, which kind of leads to sensation seeking, and also leads to lack of ability to feel empathy and emotion for other people. We don't have a lot of good treatments. There are some promising treatments kind of for those who are engaging in violent behavior, not necessarily to change the personality, but to decrease the behaviors, which ultimately, decreases or minimizes involvement within the criminal justice system. So there's some promising things out there, but we don't have a lot that works right now. Cluster C is our final personality disorder set that we're going to be talking about today. And these are the anxious, fearful group. We have avoidant personality disorder, which is often, confused with what we call, avoidant personality disorder, which is often called antisocial personality disorder. But these individuals don't want to socialize with other people, so they avoid contact that involves other people because of fears of criticism, disapproval, and rejection. They don't want to get involved with others unless they'll be liked. They show restraint in intimate relationships because of fear of being shamed and ridiculed. They're preoccupied with being criticized or rejected. They don't like new situations because they feel inadequate. They view themselves as socially inept, and they're reluctant to take risks because it could be embarrassing. So you'll see a high degree of overlap here with diagnoses of social anxiety disorder. And so in order to kind of rule that out, you kind of have to look at onset or offset. So these individuals kind of have had this throughout their lifetime. There's not, a specific onset or offset. It also doesn't respond very well to treatment. You'll see this in about 2.5% of the general population, but equal among females and males. And 10% of outpatients will have some form of this avoidant. This actually causes more distress for them because there is this fear of negative evaluation, so that and unlike necessarily social anxiety disorder, sometimes people don't want to change it, whereas people with social anxiety disorder will often want to work on changing it, taking into account cultural factors such as recent immigration, where language might be a barrier and just being negatively valued by others. But we do see that with age, like with a lot of the personality disorders, these things tend to wane. Dependent personality disorder are those people who need to be taken care of and they have submissive and clingy behaviors and they feel a separation from others. So they have a hard time making everyday decisions without advice or reassurance from others. They need others to assume responsibility for them in major areas of their lives. They have difficulty expressing disagreement with others because fear of loss of support or approval. They have difficulty initiating their own projects. They go to great lengths to obtain support from other people. They don't like to be alone. They feel uncomfortable or helpless. They're somebody who will go from one relationship to another. So once they break up with somebody, because they're too needy, they'll immediately get themselves into another long-term relationship. These are kind of the serial daters. And they are unrealistically preoccupied with fears of being alone because they're not going to be able to care for themselves. You see this more in females than males. Generally, less than 1% of the population would meet criteria for this diagnosis. We do see this in mental health clinics in terms of people seeking treatment, because oftentimes they become very distressed if they are alone, and so they want to kind of to get treatment for it. You want to look into different cultural norms and how does the culture value or foster dependency. Like in my culture in Slovenia, parents don't like kids to leave the home, and I have like adult cousins who are still living at home, like in their 20s, 30s, and even 40s, where their parents are still doing like cooking, doing the laundry, doing everything for them. So they kind of foster this dependency. You'll see high levels of comorbidity with depression and anxiety. If there's not a lot of social skills, this may moderate the dependency, so people with fewer social skills may not be able to be on their own, and that also leads to higher levels of depression. We also see that dependency is correlated with neuroticism, agreeableness, negatively correlated with extroversion, openness, and conscientiousness. And the last PD that we're going to be talking about today is OCPD. If you ever watched Friends, Monica would be a good example of this. But this is a pervasive pattern of preoccupation with orderliness, perfection, mental and interpersonal control. And these people are quite rigid, and they don't want to be flexible necessarily. So you'll see they're preoccupied with details, rules, lists, order, organization, schedules. We have a few people like this in the department, and it's hard to get anything done because they always want to do things according to the laws and orders, which is not a bad thing, but it kind of sometimes can be usurped and therefore it hinders productivity. The perfectionism interferes with task completion. They are excessively devoted to work and productivity instead of friendship and leisure activity. They're over-conscientious, scrupulous, and inflexible about morality, so it's very much black or white with them. You'll often see pack rat behavior, so they not quite hoarding, but that they keep a lot of things because they fear that they're going to need them someday. It's hard for them to delegate tasks to others because they feel other people can't do it as well as they can. They tend to have a miserly approach to money, so that they're saving their money unnecessarily, and there's kind of like a rigidity and stubbornness to them. These are people that are difficult to get along with. So these people don't necessarily feel distressed by this, but they often push people away because of these things. And so they seek treatment because they want to have, companionship, but they also have a hard time changing their personality. So you'll see this in up to 8% of the general population, greater in males and females. There are different cultural